questions might take the whole hour, but I've actually been at Stanford for around 11 years now. I'm a bit of a Stanford lifer. I got my PhD in the bioengineering department, was working primarily on new medical imaging methods development. So I did a lot of work on MRI acquisition, trying to get fast MR scans without losing diagnostic quality. Stuck around as a postdoc, decided to teach myself some machine learning. And for the past 5-6 years or so, I have been really trying to be at the intersection of methods development on the ML side, as well as useful clinical applications, because I just think there's a lot of opportunities there. Primarily been involved in computer vision, but over the last year or so, been expanding into language models, being able to work with EMR data. I've started working a little bit with Nigam and his group, which has been really great. So really the focus of a lot of the work that I do and a lot of the questions that drive my research is, we have a lot of data across the clinical enterprise. How can we most efficiently use that? How can we use that to reduce costs? How can we use that to improve outcomes for patients? That's really a lot of my primary motivation for the research. And to answer your first question, I've been faculty for the last 2.5 years now in radiology and courtesy in biomedical data science.
Awesome. Why do anything medically related at all? You probably could have been a millionaire by now if you went out to industry.
Good question. I do want to make an impact. I think maybe building the next app isn't necessarily my calling in life. It's nice to be able to improve things that matter. I have a lot of personal stories about family members going through the healthcare process, really seeing the best and the worst that it has to offer. So having some technical ability to even improve outcomes for 1 or 2 patients, I would say that would make me feel better about my time here. So I guess it's a little bit philosophical, but that's why I'm here. And that's why I love interacting with groups like this to learn and to be able to improve how we deliver care eventually.
Remind me, the stuff you're doing with the MRIs, also, what was your degree and what was your actual training in before you did your kind of real academic phase?
Yeah, officially it was bioengineering, which I don't think really means much these days. I would say my PhD primarily focused on electrical engineering. All my coursework was there. All the principles that I learned were EE focused. That, even though my official degree is bioengineering, I think of myself as a part-time electrical engineer.
Got it. Cool. And then we'll dive into that. I just find this kind of thread very interesting also because of the nature of it. The people in this room and beyond and watching online tend to be very multidisciplinary, right? And where do you sit on these sides of the fence that don't always understand each other? You hung out with electrical engineers, which is totally different than radiologists, which is totally different from clinicians versus, I don't know, like health services researcher you're kind of getting into now as well. And what have you found the interesting things that the cultures maybe can and should learn from each other?
Yeah, I mean, I think there's just a lot of opportunity being able to speak the same language and trying to communicate needs and communicate novel methods in a way that everyone is able to understand that, I think is the most fun part of my job. On any given day, I could be working on a ML paper that I'm planning on submitting to an ML conference. But the next day, we're trying to work on a paper that would go to radiology, so a very clinically oriented conference. So how do we bridge those two worlds together? How do we best communicate what is and what's not possible technologically to the clinicians? And how do we communicate what should and should not be worked on in medicine to the ML developers? And I'm somewhere along that spectrum. And it's fun being able to traverse that on any given day. And I think a place like Stanford is really perfect to do that because everyone's engaged and everyone's willing to work together. So I think of myself as a bridge. I try to spark collaborations. I try to recruit smart students and then get out of the way so the students can do the projects that they do.
Fantastic. I'm sure we more we can discuss on that and similar threads, but we're pretty well into it. Go ahead and dive in, and we're looking forward to presentation, and hopefully there'll be room for discussion at the end as well.
Yeah, absolutely. Let me go ahead and share my slides. There we go. Hopefully you can see that okay. Title slide. Lovely. Okay, so I think like we alluded to, a lot of the high-level premise that drives the research that I do is being able to improve outcomes that we have for patients. But I want to be able to reduce how much we spend and try to really maximize value in the healthcare system. So how can we really get better outcomes for patients while spending less? That is really the premise of this work, which focuses on this notion of opportunistic disease prediction and detection. So at a very high level, there's a lot of imaging data that we gather within the healthcare enterprise. And most of this imaging data answers very specific clinical questions. So this presentation will really cover, well, what if you ask different questions beyond the clinical indication? Is there any utility in asking those questions? And how might one use some of those questions to actually guide patient care? So that's the high level overview of what I'll talk about today. Here's some disclosures about grant support and other things that I don't really think will change the content of this presentation. And if it does, we can come back to that later. So overall, the first thing that I have noticed, and I think is very obvious to most folks here, is that medical imaging data is vast. At an institution like Stanford itself, we have nearly a petabyte of imaging data across the enterprise. And this imaging data could be shared across a whole host of different modalities. So here we're just seeing some examples of a brain MR scan, an EMR, an abdominal CT, a spine CT. These are very rich sources of clinical information. But the challenge is, it's very hard to be able to aggregate all of this data and to be able to analyze that. So given the fact that we're acquiring this almost petabyte of imaging data at a place like Stanford, can we really think of this as an opportunity for trying to perform precision diagnostics for disorders? And a lot of the work that will be shown here is trying to move towards this notion of precision health. Instead of trying to treat someone in a personalized manner, can we actually look before that in the disease pathway itself? Can we actually understand some of the earliest transitions where we go from a healthy state to a disease state, so that hopefully we don't even have to treat that person for having a disease because we'll be able to manage it preemptively? So is there an opportunity for using some of these large data sets that we have in medicine for these precision diagnostics? And with this in mind, I really wanted to focus on a pretty specific imaging modality first. And here is an example of a CT scan that are performed across multiple different modalities across the US annually. So if we look at the number of annual CT scans, we'll see that the incidence is massive. There's around 20 million CT scans that are performed of the abdomen, around 15 million CT scans that are performed for the brain, similar number for the chest. So we really have a potential to be able to look at broad population level insights using this imaging. So given the fact that I wanted to be able to explore precision diagnostics, I figured that looking at these very high dimensional images that are very common across the country could be a good place to start. And I think the simplest place to start was looking at the scan that's the most prevalent. So I really wanted to focus on abdominal imaging. So abdominal CT scans are probably the first resource if you go to an ED setting. If a patient is complaining about abdominal pain and they present to the ER, most likely they'll be undergoing an abdominal CT. So there's around 20 million patients that are unique in the US that undergo an abdominal CT. So is there any utility that these methods could have for some precision diagnostics? So while this is great, there's a bit of challenges though when we're working with these very high dimensional data sets. So here's a movie, hopefully it's playing okay on the TV over there, but these 3D CT scans are very dense. There's a ton of information in them. Just from a data modality itself, the dimensions of the scan are on the order of 512 by 512 pixels by around 300 to 500 slices per patient. So there's a lot of density of information that's contained in here, which becomes a little bit of a computational challenge, but it also becomes a challenge in terms of what are some of the right questions we want to be able to ask. And because of the scale of this data, in terms of how large each data set is and how many data sets are actually required nationally, this is not something that's really amenable to manual analysis. And right now, the way we're using all this imaging is the clinical questions that we're answering are limited by the indications for why the scan was performed in the first place. So while all of these really are challenges, I really think of it as an opportunity. We're building a lot of novel machine learning based methods. So can we use that to automate some of the analysis? We're right now only looking at clinical indications. Can we ask other questions? So everything that's a challenge, I think, is just a coin. And if we look at the other side, there's an opportunity that we really want to be able to extract over here. So motivated by this and motivated by trying to have precision diagnostics across a large cohort of the population, it's quite common for an older segment of the population to undergo most of these abdominal CT scans. So at Stanford itself, the average age of patients undergoing CT scans is on the order of 63 years old. So if we try to characterize what sort of diseases one might even look at, it's interesting to look at what are some of the most common chronic disorders for older populations in the US. And these are some of the top 10 diseases. And if we actually dive into some of these, I think there's a lot of potential for looking at diseases like hypertension, cholesterol, ischemic heart disease, diabetes, chronic kidney disorder, and heart failure. All of these have, these are all cardiometabolic disorders. So there is potentially a hypothesis that one could have that maybe there are some indications that could be viewable on these abdominal CT scans that we're acquiring in the clinic. So can we actually look at the incidence for some of these diseases? Can we actually predict the onset of some of these disorders? And the benefit here is a lot of these are comorbidities for each other too. So here's a nice little plot that we're able to extract by looking at a lot of publications that looks at the interconnectedness of different diseases. So the color of these the size of each of these plots is what is the percent of the population that actually has the disease. And the color of the arrow indicates what percent of the population that has hypertension also has osteoporosis. What percent of the population that has hypertension also has ischemic heart disease. So we can really see that this is a pretty interconnected graph. So if we have a potential to identify one or two of these, then we have a pretty high potential to be able to really understand this broader category of cardiometabolic and musculoskeletal diseases that we end up seeing. So the benefit here also is a lot of these early diseases can have clinical steps that could lead to trying to treat the disease or actually trying to intervene in a defined clinical pathway. So for example, if we suspect someone to be at a high risk for cardiovascular disease, we can initiate statins, we can prescribe them for additional coronary calcium scans. If someone is at a high risk for hypertension, there's a whole host of therapeutics we can prescribe. Same thing on the osteoporosis side. And this list really goes on. So all of these diseases, if we have the ability to find a high risk population, we can triage them appropriately. And there's clinically defined pathways that we can put the right patients on. So this notion of being able to analyze some of these images that exist already is just trying to find who are the high risk patients and then trying to steer them into the clinical care system so that hopefully we can just prescribe a statin to someone today instead of them having a myocardial infarct 5 years from now, and then them coming to the same hospital anyway. So this is really the high level notion of what motivates some of the work. And why I think this is possible is because if we look at something like an abdominal CT, there's a lot of quantitative imaging metrics that we can extract from here. For example, there's a lot of information that we can glean by being able to extract visceral and subcutaneous fat that's prevalent within this. So fat is commonly being acknowledged as a really interesting biomarker for looking at inflammatory processes within the body. So if we can analyze some of these trends, we can really better understand inflammatory states and how they affect cardiometabolic disorders. In addition to that, we can look at things like muscle density that have been implicated in disorders like sarcopenia, which is just a broad confounder that is related to a whole host of downstream disorders. We can look at liver characteristics, so we can understand whether or not patients have steatosis, do they have fatty liver, are they at higher risk for developing HCC in the future. We can look at calcifications in the aorta itself. These are potentially early signs of atherosclerosis. Right now, we mostly look at these calcifications in the coronary arteries, but atherosclerosis is a generalized event. So if we have larger vessels where we might see calcification starting up early, maybe this is the best way and time to intervene in those patients before they have an MI later. And we can also look at metrics such as the bone density. So there's a lot of risk for older patients and having disorders like osteopenia and osteoporosis. But if we can just quantify their bone mineral density, maybe we don't need to prescribe a DEXA scan, which has only 10% utilization as compared to what it should be receiving. So all these biomarkers are apparent in these CT scans, but just not routinely quantified at all. And I think this is what the promise of a lot of machine learning methods has, to be able to automate some of these measurements and use them for downstream clinical outcomes. Yeah. So in this particular presentation, I wanted to briefly share 3 research vignettes that we've been able to glean over the past couple of years in this work. So the first question will be, how do we actually look at some of the data sets that we're acquiring for being able to opportunistically predict the incidence of future disease? And here we'll be focusing on the #1 killer in the US, which is ischemic heart disease. Next, we really want to understand, well, what are some of these diseases that this paradigm of opportunistic imaging can actually help you with? And right now we're building some end-to-end models just to understand whether there's any signal in these images. But once we actually see that there's some signal in predicting future disease, that's a really nice hypothesis generator. So why is my model predicting particular diseases? Are there any actionable biomarkers that we can extract? And lastly, some of these notions of opportunistic imaging can be used to remedy underdiagnosis that we can have within the clinical system. And I'll be focusing on the disorder of sarcopenia. So hopefully we'll give you quick 5 or 6 minutes descriptions for each of these vignettes. So the vignette #1 that we had was ischemic heart disease is the primary cause of global mortality, very high prevalence in older populations. So can we leverage some existing data that we have already to be able to predict the risk of future ischemic heart disease development? So if we have healthy patients that are undergoing some abdominal CT scans, can we actually predict how many of them have a 5-year risk of having an ASCVD event through this IHG diagnosis? So the pipeline that we used for this particular project was we extract an abdominal CT scan, and just as a very naive way of doing this, we look at a single slice in this abdominal CT scan just to simplify some of our analysis. And we pick a slice at the L3 vertebral level. And we pick the L3 vertebral level because there's a fair amount of prior work that's being done that has looked at body composition at this particular level, because there's a nice depiction of subcutaneous fat, visceral fat, as well as muscle that can be visualized here. And then we can automate the extraction of this body composition. So these are some imaging-based metrics that we can extract. And then next, we can combine this information with what's available in the patient's medical record. And when we integrate both of this, our goal is to use our imaging insights and to be able to use some prior data from the EMR to predict who's going to get future ischemic heart disease. And a lot of this is possible because we're now able to take our images and to be able to quantify things like muscle and fat with very high accuracy. And we've shown a variety of automated segmentation methods that have nearly indistinguishable performance and segmentation between machine as well as human within the same inter-reader and intra-reader variation. So now we can really extract some of these quantitative biomarkers, which have been previously validated, but now we can extract these at scale. So for this particular analysis, we started off with an initial cohort of all patients who had consecutive CT scans at Stanford between 2013 and 2018. And we built some follow-up criteria where we looked at around 8,000 patients that go on a cohort of 8,000 patients that we follow for 1 year prevalence of ischemic heart disease, and a smaller cohort of around 2,000 patients roughly where we have information across 5 years. And we're trying to evaluate the 5-year incidence of ischemic heart disease. And here are the results. There's a lot of information in here, but let me guide you through these step by step. So at first, in our cohorts, we're only looking at some of the 5-year results right now. We wanted to compare what the clinically used instruments are. So we evaluated the Framingham risk score as well as the pooled cohort equations. And then we got AUROC and precision recall values of what's been explored in the literature. So this was the baseline performance. The next, when we added in some additional data that's typically not considered in most of these risk prediction models, we looked at some of the segmentations only. So just looking at the muscle and fat, nearly has the same performance of using all the covariates that are used in clinical tools like the pooled cohort equation. So that was interesting and surprising. When we add some of the segmentation to the pooled cohort equations, we see improvements in performance. When we just use images only, so we take our L3 slice, we feed it into a neural network, and we just ask it to predict which of these patients are going to develop future disease. But we saw significantly improved, oh, why am I slide? Yeah, we saw significantly improved performance. But then what was really interesting is when we actually combine all this information together. So we have imaging data, we have medical records data, and we have all these segmentation models, we get significantly higher performance, both compared to the Framingham risk score, as well as the pooled cohort equation. So this really speaks to the power of potentially using some multi-modality information and trying to make best use of all the data that we're sitting on. We have images and we have prior medical records. Let's try to build the best prediction model that we can. And we're very pleasantly surprised at how much utility a method like this could potentially have.
Can you pause for a second? Go back to that one because you got a lot of good stuff there.
Yeah.
You're stating what was the clinical thing, and also, but maybe many people may know, many people may not know in this eyes. What is the Framingham risk score, and versus clinical? I wasn't clear what the difference was.
Yes, sorry. So I can emphasize that a little bit more. So right now, I'll probably talk about the pooled cohort equations because that's what is used most commonly in cardiology clinics. And the pooled cohort equations use around 7 covariates. So they look at things like age, sex, they look at your cholesterol values, they look at smoking status, and they look at a history of diabetes. And I might be forgetting 1 or 2 of the covariates, but basically it's a simplified model of trying to predict 10-year risk of events. So we obviously, this is not the fairest comparison because we don't have 10-year outcome data. We only have 5-year outcome data. So that was the baseline that we're comparing. And then when we're talking about the clinical model, we're utilizing all the information that we have in the patient's medical record. So we did a little bit of analysis and we tried to take all the data that we can extract from, let's say, a star data dump, and we filtered it down to around 130 different variables that we're using. And this includes ICD codes, this includes some procedures, it includes, let me see, it includes some medications. So we tried to have a bit of a systematic approach to take all the EMR data, condense it down into things that might make sense for cardiovascular risk. And we ended up working with around 130 different variables. So that's a clinical only model. So does that answer your question, John?
I got one too.
Yeah.
Follow up?
I have 2 questions. Go ahead.
So if you're interested in actually applying this in practice, why are you reporting area under the ROC curve rather than identifying the cost, what the cost of different error types are, and then picking the right point? That's what you care about, right? Not some single number that doesn't make any commitment to the cost of errors.
Yeah, fully agree. So I think
you're just doing this to get published, or do you actually believe that ROC curves are useful in medical practice?
I mean, that's a bit of a provocative
yes,
question,
it was.
But yeah,
it was provocative of you to use the ROC curves.
It is, but I think you have to start somewhere, right? So I think we're really trying to build some models as the first place. Are we going to use these models directly in clinical practice? No. I think there needs to be a lot more of a nuanced perspective to be able to do this. So even if we look at the pooled cohort equations, for example, there's different risk types that you can have within that. All of these curves are calibrated. I think what would be really useful as a next step for us to do, which we're actually currently doing right now, we don't have the data to share, is with our opportunistic imaging approach, what is the net reclassification that we can actually achieve? So are there patients that we're missing out with the pooled cohort equations that we might be able to reach with our approach? So is this the way we'll implement ideally in clinical practice? No, but I think from a model building perspective, I think this is a good first pass as some preliminary data to convince yourself that this might be a technique worth spending more time on and being able to really optimize it methodologically first, and then trying to understand, well, which of these methods make most sense for deploying it in the clinic in the future?
Thank you.
So it's a
Next question.
stepped approach.
I'm going to ask questions one at a time because they are sequential and may not need to ask all of them. So number one, excuse me, the Framingham risk score, if it is higher, what do you do for that patient? Because the risk is 5 years from now, and given that AUROC is say 0.71, for all the criticism of AUROC, you can say that at 0.7, your sensitivity is about 50% and specificity is somewhere around 60, 70%, right? So your false positive and false negatives are really high. So given that, what is it that you do with a patient that has high FRS right now?
Yeah, so right now the clinical guidelines are, depending on what sort of risk you have, either with your Framingham risk score or your pooled cohort equations, you have a conversation with your cardiologist and you really try to understand whether you as a patient, based on your lifestyle, should be put on statins. So statins have shown to have good outcomes when patients with early cardiovascular disease have been prescribed. So then at that point, now that you know that you're at risk for cardiovascular disease, the next step in the clinical pipeline is to understand, should you be put on statins based on prior existing conditions that you might have, whether you can tolerate statins, and then what sort of intensity of statins do you need to be on? Because the intensity really depends on the risk of disease that you have. So then we're basically trying to take these patients that may have a risk and then trying to have them have that conversation with their cardiologist. So we're trying to find a high-risk population and then steering them into the routine clinical pathways where this practice has been established. So the intervention that you'd most likely be getting in this case, if you have a high risk, either via Framingham risk score or the PCE, would be statin initiation. And that is the outcome that a lot of studies look for.
So the difference would be get statin, don't get statin, after talking with the cardiologist. Now, there is at least 50% sensitivity and specificity. So the 50% are talking to cardiologists who don't need to, and 50% who need to, but are not talking to the cardiologist. Going from 0.7 to 0.81, 0.71 to 0.81, right? Like the lowest and baseline and the highest. You are increasing that by roughly, I want to say somewhere between 10 to 15% on both specificity and sensitivity. Great. Now, one of the input for your clinical fusion part was medication. Were any of these people already on statin? Like the conversation had already happened, and that's what is actually increasing your AUROC. Do you know that? Did you look?
We had removed patients who were on statins before.
Okay.
But they could be on antihypertensives or other cardiovascular drugs, beta blockers, and so on.
So
What's the pooled cohort equation? That's an input to those too.
right. So is that so? The reason I'm trying to ask that question is, EPIC was diagnosing sepsis for those who were already on antibiotic, right? Is that what is happening here?
No,
Sounds like you separated here.
Yeah, it's separated out. Yeah.
Okay, great discussion.
Yeah. Any other questions before I continue?
If you want to go, Sujat.
Yeah, I do have a question about how did you combine the two modality of the data that you have, the imaging data and clinical data, and how you trained your neural networks?
Yeah, so we took a relatively naive approach to do this. By building some of these fusion models, we relied on kind of some of the simplest methods to do this. So we have a deep learning-based classifier only, so that's an end-to-end model. And we have separate clinical classifiers that we use models like XGBoost on. So then, by trying to combine this, we use the typical early fusion versus late fusion approaches, where we have separate regressors, and then we build a meta regressor on top of that uses both the separate inputs. So that was, we experimented with a lot of different approaches. We built neural networks that can accept clinical data too, but I think that was just overcomplicating the problem. So a simple approach of having separate classifiers and then building a meta classifier on top of that with the late fusion approach was what worked the best in this particular case.
Thanks.
Yeah. Okay, so maybe I will continue.
Yep, keep going.
Yeah, So I think some of the interesting insights that we found over here was we can get some sort of understanding about why our models are making specific predictions at the cohort level. And we can actually extend this to potentially understanding some patient level risk factors too. So at the cohort level, we found characteristics that one would expect as to why someone would have higher risk of cardiovascular disease. And this is basically using some ICD codes, some vitals. And this gives you a nice cohort level description. But now really trying to understand how do we take these insights and then try to treat a patient at any given time. We can do some imperfect interpretability methods. But at the bottom, at a patient level, we see why someone might be predicted with a higher risk. Maybe they have some other forms of heart disease that have been diagnosed. Maybe they have other hypertensive disorders. Their age might be a risk factor that's increasing their risk. But in blue, they have something like a low diastolic blood pressure, which is reducing their risk. So this is just a little bit more of a tool as to understanding why a model is predicting risk, as opposed to just throwing some data into a neural network and just not knowing any sort of interpretability as an output. So this is an initial approach that we have about just trying to come up with methodological approaches to combine imaging data with some EMR data sets to be able to build these risk prediction models. So overall, as a summary, like I mentioned, I think there is some signal, and then there's an opportunity of combining these different modalities for trying to stratify for IHD risk. So vignette number 2 that I wanted to share was, okay, we have some information about trying to diagnose future risk. Well, how far can we really take this? So we really wanted to understand the fact that since a lot of cardiometabolic disorders they share some risk factors amongst them, is there a signal in our images that can be used to look at multiple different cardiometabolic risk factors? Again, I'll emphasize the point that the models that we're building here are not models that we necessarily want to implement in the clinic. We're just trying to see whether there's features that could be perceivable via some deep learning based methods to actually predict the onset of future risk, so that we can come back and say, okay, my model can predict the risk of disease X, Y, and Z. Let's try to understand why that's happening, and are there some new insights that we can glean from these model predictions? So the way we built this pipeline was, we started off similarly with our 3D CT volume. We extracted a single slice at the L3 vertebral level, and then we just did some naive pre-processing. We built a simple segmentation model to look at the aorta and the vertebral body. And then the reason for doing this was we just wanted to build a poor man's 3D representation of this image. So we take a dense 3D volume, and then we extract an axial slice, we extract a sagittal slice that mostly goes through the midpoint in the left to right direction, and we extract a coronal slice that's centered on the aorta itself. And our hypothesis for this was building neural networks that would accept as inputs a full 3D CT scan volume. There's probably going to be a whole host of different spurious correlations. So if we try to simplify how much information we're feeding into these models, maybe we'll get a little bit of an unbiased perspective of what might be some of the features that are driving the risk of these disorders. So the input to our model was this multiplanar axial, sagittal, and coronal mechanism. And we really wanted to see, given all of these images, is there potential signal to be able to opportunistically predict the 5-year incidence of hypertension, osteoporosis, diabetes, chronic kidney disease, and like I described, ischemic heart disease. And we're doing this in an end-to-end manner as a hypothesis generation tool. And we looked at a few different approaches. This is more from a technical perspective of what is the value of adding axial slices? What is the value of sagittal slices? Because all this represents a little bit more and different information about the modalities. And we also looked at multitasking networks. This is more from trying to be a little bit more data efficient. So are there benefits of using a single model to predict all the disorders where there's shared information that models can gain by trying to predict everything in a multitask manner? Or is it better to build an individual, very focused model to predict singular diseases? Well, our take-home message through a whole host of hyperparameter optimization here was it's best for the models to be able to use as much information as they can. So this led to the models performing best when we used all three images as an input, and we built some multitasking models to be able to predict the risk of future diseases. So again, I wouldn't necessarily belabor the points, and I don't think the AURC values, I think we've talked about that a little bit already. They're not necessarily meaningful in and of themselves, but I think the fact that we're getting some relatively moderate AURC values over 0.75 or so shows that there is potentially some signal that could be extracted from these images. And potentially it's not necessarily very surprising. If we look at a coronal, I'll go back one slide. If we look at a coronal slice, we can really visualize the liver quite well. And we know that having a fatty liver is a generalized sign of reduced or a high risk of some cardiometabolic disorders. We can visualize the aorta really nicely, and we could potentially see some sort of calcifications. Middle slice, we see and now we know that all these cardiometabolic disorders, they're somewhat linked to one another, and this will help us assess our future hypotheses that, okay, let's really understand why is your model able to predict chronic kidney disease? Why is your model being able to predict the onset of future diabetes? What are potential risk factors that the model is looking at? And we really want to be able to combine this information with the medical records that we did with the prior ischemic heart disease diagnosis to really get the best of both worlds. So I'll maybe pause because I imagine there might be some questions here or concerns.
Sorry, go ahead. Is the diseases you're looking at here, are these based on ICD-10 codes, or what measures are you using?
Yeah, so right now we're using ICD-10 codes, which is an imperfect measure of trying to really understand who develops future diseases. We just had a nice paper accepted to a NLP conference where we're actually building an NLP-based classifier that automatically goes through clinical notes and tries to assess the first incidence of a particular disease. And we did quite a few robustness analyses over there. And it turns out that there are patients where some of these disorders are missed, and sometimes the timeline of the disorder is off. So maybe a clinical note might say that my patient is taking statins for cardiovascular disease, but their ICD code doesn't actually represent that disease 5 years later. So there's some imperfections in trying to have really good labels as a gold standard, but we at least wanted to start with something simple, something structured that we could use. And right now what we're working on is really trying to have a gold standard cohort where we find a disease using ICD codes, and we find it using clinical notes too. So we need the intersection of both of those. And I think that will just help increase the signal to noise ratio in the labels that we're generating.
Here's a broader question probably about all your work. You formulated this as a classification task, but clearly you can have these diseases to greater or lesser extent, or they can be more or less severe. Why did you choose not to formulate it as a regression task?
Well, I guess it would depend, right? So I don't necessarily know of a good formulation for regression for something like atherosclerotic cardiovascular disease. It's unclear whether your risk necessarily stratifies linearly what regression tasks are using. So if your pooled cohort equation is giving you a risk of 0.1, what does that really mean? Does it really make sense to have it regress to the same risk as a PCE? So while I understand your question that there's a range of diseases and there's a range of severity, if you're using it to build a regressor, then there needs to be some sort of quantitative metric that you can assign as a gold standard. And I'm not sure we can necessarily do that. If we can, I'd love to chat a little bit more, but at least
I'm not an expert in the area. If the doctors cannot assign a number like that, then obviously you can't work with that. But I mean, I think we all have the intuition that in principle, one could. And I just was asking, so it sounds like you have good reasons why this is the only game in town. For now.
Yeah,
anyway.
yeah, and I think we might be able to look at different severity of disease. So instead of saying yes or no for ischemic heart disease, you might be able to subtype to severe disease, moderate disease, mild disease, or no disease. That is at least how clinicians are taught to think about it, and that's how they actually base their interventions on too. So if I have a high risk of disease, I'll prescribe patients on high strength statins. If I have mild disease, then maybe we'll wait and watch. So I think there could be a nice happy medium compromise where we don't necessarily have to go to a regression task.
No, you could have an ordinal scale of some kind. But the reason I ask is, the reason I ask is because from what I've seen, how you formulate a problem is a major determinant of the success of an application of machine learning. And it's always worth asking, is this the only formulation? Is this the best formulation, and so on? So you gave a good answer. Thank you.
So I can't see if there's other questions. Yeah.
Yeah, no, let's keep going. I'm sure there'll be more, but let's keep going.
Perfect. Yeah, I'm just trying to be mindful of time, 12:43. Okay. So maybe I'll skip this part, but basically we're able to build this model while using less data. I can all come back to that if people are interested, but maybe I'll skip for the sake of time. So the next vignette that I wanted to talk about was something that we're able to find some interesting observations at Stanford Healthcare too. So we have some of these opportunistic imaging tools, and we really wanted to understand, are there particular disorders that we're missing that we could potentially code a little bit better? Maybe the coding could improve how clinicians think of the patients. And in terms of some of the codes that we looked into, we really wanted to understand the presence of sarcopenia. And the reason we look at sarcopenia is because there's a lot of visible biomarkers that are visible, that are seen in abdominal CT scans. And just at a high level, sarcopenia is defined as a significant loss of muscle mass and function. So there's no formal definition that if your muscle function is above some threshold, then you have sarcopenia. So this is a pretty imperfect definition of the disease broadly, but we know it's important because sarcopenia for the last few years has been really strongly implicated with higher mortality, with higher risk of falls and osteoporosis. If you have any sort of major surgery, if you have underlying sarcopenia, you're just at a much higher risk for recovering. Your recovery is going to be much slower. So if you can think of sarcopenia as a general measure of frailty, I think sarcopenia has been implicated for a whole host of different disorders. And there's no gold standard metric for diagnosing sarcopenia. There's some measurements that people use as like a grip strength test, but that's not performed routinely. Grip strength testing isn't necessarily standardized in terms of the protocol. So there's a lot of poor sensitivity in trying to diagnose this disease. And we wanted to investigate this because on our images, we can evaluate and visualize muscle mass really well. So we just wanted to see, well, what are the implications of being able to diagnose this and compare that to how's that really being done at Stanford? And one of the reasons we were, again, interested in this is right now, people use BMI as a surrogate for frailty status and really trying to understand performance. But here are examples of 3, I believe, 60-year-old male patients with the same BMI, but different body composition. So here on the left is a normal BMI, and we can see a pretty heterogeneous distribution of visceral fat. So that's all your adipose tissue surrounding the internal organs. The subcutaneous fat is all the fat that's on the periphery of the body, and then all the skeletal muscle that we're evaluating. But now there's a similarly aged and BMI matched patient, but their body composition distribution is completely different. So they have significantly higher visceral fat compared to all the other patients. And here, there's a third patient, again, with the same BMI that has a completely different distribution of visceral to subcutaneous fat. Right now, a lot of the clinical guidelines and the clinical workflows that we look at use this imperfect measure of BMI. And based on this measure of BMI, all 3 of these patients receive the same care. And the risk of disease is interpreted in the same manner, but clearly, if we actually look from this visual perspective, there's different phenotypes. So we really want to be able to distinguish these different phenotypes. And I think sarcopenia is a confounder because this is what's actually modulating these three phenotypes. So what we did was we built our segmentation tool to automatically quantify how much muscle this particular cohort had. And when we looked at this cohort of 23,000 patients at Stanford Hospital who received an abdominal CT scan, we're able to take that overall muscle mass, and then we scaled it by the patient's height. So we're trying to have a similar formulation of BMI, and then we just called that the skeletal muscle index. This is something that we did not create. It's something that's being used commonly in the frailty community. It's a score that's used pretty commonly to assess sarcopenia. And we just wanted to build some of these normative curves that describe the population in terms of what their skeletal muscle index is. And we're able to stratify this across age, and we're able to stratify this across race and ethnicity. And we really use this to build calibrations of, if I am a 35-year-old patient coming in, how do I compare to my peers who are in the same age bucket, who are the same race? How can I actually have a quantitative comparison? And to do that, we're able to build some T-scores that really compare a given patient to the entire population. And this is really inspired by a lot of literature in the osteoporosis space. A lot of DEXA-based work uses these normative T-score distributions. So we built these T-scores around 17,000 adults. And based on this, we can build cutoff for sarcopenia diagnosis. So any patient that has a T-score less than -2 can be defined as being sarcopenic. And one might argue, well, what is the best range? People say they should be below 2.5, they should be below 1.5. I don't think the specific number matters initially for this exploratory study, but having a T-score less than 2 is a pretty good definition of what sarcopenia status should be. So we looked at this cohort of around 17,000 patients, and only 9 of them out of 17,000 were actually coded with sarcopenia, compared to around 3,000 of them being coded as obese. If we look at their radiology report, only one radiology report out of 17,000 had a report of sarcopenia, versus a few of them reported on obesity. And according to our quantitative criteria, if we can actually extract some of these muscle-based scores, around 30% of the population should actually be categorized as sarcopenic. So we just thought that this was a pretty interesting study where now we have these automated tools to be able to characterize a very large cohort of patients. If we can help better coding, then their primary care physicians might be able to better understand what their innate risk factors are. So I think this could be a nice quality improvement study, as well as new research directions that this could enable by automatically being able to characterize patients into different groups based on their muscle status. So overall, we showed that some of these opportunistic.
Pause for a second. They can go
So,
ahead.
aren't you creating an epidemic of sarcopenia now?
You're creating a new disease. They were fine before. What are you asking?
Well, so I think I am definitely not the clinical expert in the management of sarcopenia, but as of 4 years ago, sarcopenia is a new code that has been added. And I think sarcopenia, the reason one of the codes was added was because it's a useful covariate to have in trying to understand how patients might respond to major surgery. So we're actually following this in some cancer-based outcomes. Patients who had sarcopenia at the time that they underwent either surgery or chemotherapy have much worse outcomes than the patients without sarcopenia. So I don't think it's necessarily adding a new disease. And I know it's a point made in jest, but I think we're just trying to see whether it's helpful to bring attention to this, to better stratify patients and better trying to understand personalized therapy. So if patients with underlying risk of sarcopenia prior to chemotherapy have a higher risk, then maybe we'll prescribe prehab. Maybe we'll prescribe better nutrition management to be able to treat different patients differently. But I think I agree. So I think we're documenting something that could be more work, but I think there's research to be done whether this documentation can actually improve patient level outcomes too.
Great.
Perfect. I'll continue moving 1252.
So Akshay, I just looked it up. It's a billable code, so people will run after this for sure. M62.84.
There you go. An extra 500 bucks for hospitalization. All right.
Yeah, probably adds $500 per hospitalization. Oh my goodness, this will be an epidemic.
Yeah, so I guess we can talk about what the strengths or the weaknesses of that method, but I think that's initially what had caught our attention too, that only 9 of these patients were coded. And we actually tried to see who coded this. There was just one physician who had all 9 of these codes, but I think there's some, there's definitely some reimbursement-based arguments one could have to upcode more complex patients too in this case.
Back to the ROC curves.
But yeah, so as an overall, through the 3 vignettes, I think I don't need to belabor their point here, but I think there's a lot of information that's available in these imaging studies that have been performed already. And if we combine that with other sources of information, such as the medical records, then there's potentially some benefit to look at diseases as they progress in the future, being able to catch them early from a precision health perspective, in trying to come up with some systematic underdiagnoses of disorders too. Whether or not we need to implement this, all of these methods clinically, time will tell, and I think would love to have some more conversations about that. But I think it's interesting to be able to build out a nice tool set to enable all of this work. And towards this end, we've made all of our medical imaging software that does this completely open source and available. So we built this tool called Comp to Comp. It's available on GitHub. Anyone can download it. But if you get an abdominal CT scan, by running our tool on it, you can automatically extract bone mineral density. You can automatically extract muscle as well as fat status. You can perform segmentation of the liver, the spleen, pancreas, trying to understand steatosis over there. We're building a module to automatically quantify aortic calcifications. So we think that there's a lot of information embedded in these scans. We just need some tools to be able to extract it. And we hope that some of our open source solutions can really help towards that. So if people have questions or if people are working with their own imaging data sets, please feel free to check that out. And I'll skim through, I'll come back to future approaches. I think I just, again, want to emphasize the point that a lot of its initial exploratory work is not necessarily a risk model that we want to implement in the clinic in the future. I think we just really want to be able to use some of these imaging studies to better understand whether there is any predictive power in the images. And if we do find that, really go back to the drawing board, really understand and really interface with the experts and the clinicians in that disease to understand what can we do with these methods in a way that's interpretable and actionable for the clinicians, and if that even makes sense in the first place. And I think towards that end, I'll just briefly mention this study where a similar notion of opportunistic imaging was used to analyze routine chest CT scans to measure coronary calcium. So normally, to measure coronary calcium, you need a gated CT scan, which is synchronized to your heartbeat. And then using that, you can automatically, you can identify the specks of calcium in your coronary arteries. But if you just look at a non-gated CT scan that's not synchronized to your heartbeat, everything you can imagine will be blurred out. So a lot of the coronary calcium will have a very blurred out appearance. And that's why these non-gated chest CT scans aren't used for coronary calcium analysis. We built some methods, we as in a large team, built these methods that compared to a coronary calcium scan, my slides are not advancing, we can look at routine chest CTs and automatically extract the same coronary calcium. And because there's clinical guidelines for what to do when you detect coronary calcium, we can actually take some sort of clinical action. So like I mentioned before, if there's high coronary calcium, a cardiologist would want to initiate statins. So what we did was we looked at a study of around 350 patients with no prior cardiovascular disease risk, and we noticed incidental coronary calcium on their scans. So we sent a notification to the patients as well as their PCPs that, hey, you had a scan at Stanford, we found this coronary calcium. We encourage you talking to your cardiologist or your care provider to see how this might affect your future risk and what sort of future action you should be taking. And in this matched study with 170 patients per group, in the arm that got notified about their coronary calcium, half of them initiated statins within 6 months versus only 7% that initiated statins in the control group that did not receive notification. So not receiving a notification is the standard of care. But I think this is just a nice example of how we could use this information and really try to incorporate that in the clinical workflow. So again, I guess I won't belabor the conclusion, but lots of information available in these images. We can combine this in a multimodal manner. We're combining this with the EMR, but we're doing work on trying to extract insights from clinical notes too. And we're trying to see how some of this could be useful for clinical follow-up. So I think lots of open questions, lots of lessons to be learned, but always happy to chat more about this. And I definitely do want to acknowledge a lot of the folks that really made all the work possible. So here are all the PhD students, Juan Manuel, Lewis, and Arjun, who did all the hard work here. We collaborate extensively with a host of radiologists on the bottom and a host of cardiologists, and thanks to our funding sources too. So happy to take any questions.
All right. Just got a couple minutes. Anybody want to squeeze in a question or two? So, some super quick ones. How did you train this stuff to know what bone density is and liver mass? Like someone had to manually annotate to death. Where did that come from?
Yeah, so we tried to build tools that are pretty data efficient. So that's one of the other focus of my research group. Can we go beyond these notions of supervised learning where for every image, you need some sort of label? So we're building tools that rely on self-supervised learning where you're actually using unlabeled data to learn what does a CT scan look like. And we did have to label a fair amount of these data sets, but we tried to make full use of what's available in public data sets. And now we're just being able to validate all of that on Stanford data. And on average, most of these perform quite well, but it was a little bit of a painful experience getting all the data sets together, but we combined that with some very data efficient deep learning tools too.
Do you show learning
And that's
curves?
why we're making this available.
Can you show us learning curves?
Right
That is
now, no.
accuracy. Well, but I encourage you to report them because that's the real question. If you're going to make claims about the rate of learning, report the accuracy or ROC score as a function of the size of the training set.
Yeah,
That's not done often enough these days.
I mean, I would push back a little bit on that. I think your accuracy curves don't necessarily always represent what the real life performance of your algorithm would be. If it all depends on what your data distribution is. You can have data that's in distribution and you could have perfect training lots, perfect training curves where your training curve follows the validation curves. But as soon as you move your data distribution, those curves might not have enough credence. So I think
no, I'm not talking about. I'm talking about a learning curve where the dependent variable is performance on a separate test set.
Oh, okay, got it. So that's different than the traditional learning curve that people report in deep learning studies.
What I described is a traditional learning curve. You're talking about something else, I think.
I guess different language is still more to be learned.
Yes.
Yeah.
We're wrapping up. I'm going to ask a broad conceptual question to close it out.
Yeah.
This is a little bit beyond the imaging work, but
yeah.
It's about this opportunistic, right? These are not people, you didn't CT scan every primary care patient and see what happens. They happen to get a CT for some reason. There's some selection there. What do you think? Maybe everybody should just get a full body CT scan and just run them through your algorithm and everybody pay $1,000. You'll discover all sorts of interesting things, right?
I mean, I think they used to have that in malls, right? Like back in the 90s, I heard, where you could get a CT scan. I'm not proposing we do that yet.
Why not? You've discovered all this cool stuff you can find.
Yeah, I mean, I think there's still the risk of some radiation that the patients are getting. I think there's a lot that can be done on the image acquisition side too. So there's some new generation CT scanners that are coming out, the photon counting CTs, that probably give you very adequate resolution for some of these analyses without necessarily exposing yourself to as much radiation. But I think before we get there, before having a screening CT, I think we need a lot more systematic studies that show that there's benefit in some of these incidental findings. So, just because we can quantify liver fat, or just because we can quantify sarcopenia status, doesn't mean that's useful, doesn't mean it's cost effective. So I think there's a lot of steps to be taken before we're anywhere close to making that claim. Maybe we will be when our CT scans provide the same radiation as a chest X-ray or a transatlantic flight, but that would require some large-scale RCTs and cost-effectiveness research to really understand whether or not that should be done.
If you end up showing this to people who do CDI, clinical documentation integrity, they will go after the $500 for the M62.84.
Sure.
Like, just be
Is
careful.
that a good thing or a bad thing?
It depends on who you ask.
Depends on what kickback you get.
There's certain rules on kickback, but
Sure.
yes, there are incentives. And there actually is one online question I want to make sure we get to. Julie Wu, hey, for cancer patients, how do you distinguish what's a tumor tissue versus normal tissue? And then I think we can close it out.
Yeah, so for cancer patients, what's the difference between tumor? So I don't think we're explicitly trying to make differences between what is cancerous and what is not cancerous on a particular disorder. So I think as we build some of our normative reference curves, so for example, when we're looking at muscle, we don't necessarily expect there to be like a muscle-based tumor. But I can see what that question would be if we're trying to do some sort of analysis of trying to look at liver fat. So we'll try to segment out the entire liver, but maybe there's a few masses in the liver. So right now, I think our approach is relatively coarse. We group everything together, but we can probably improve some of our segmentation models to explicitly look at normal tissue when we're trying to build out some of these normative reference curves. So we're not necessarily confounding our metrics based on these different subtypes of tissues that we're seeing. So that's a good point. But we haven't necessarily gotten there yet because none of our clinical questions have relied on having that distinction.
Yeah, it's a great discussion. I'm sure there'll be a lot more fun stuff to follow up on. Thanks for connecting, and we'll catch up soon.
Yeah, thanks so much. Really appreciate the invite, and it was great to answer all the questions. Thank you.
See you soon.
Is this
Bye,
camera
all.
working
Thank you.
now?
It is. It's actually been looking at you the whole time.
Yeah, I see half the room. Yeah.
Usually that's the camera that's working. This is
Bye, all. Thanks.
good then.
When you ask your